Good afternoon, everybody. Great to see everyone here. Welcome to the first CAP Echo meeting for this cohort. My name is Joanne Jung. I'm a general pediatrician, and I'm the Senior Associate Director at CAP, and I direct our continuing medical education programs. And as people are coming in, I'll let the rest of our hub team just quickly introduce yourselves. So I'll pass this on to Lauren.
Hi there. Nice to have you guys joining us. I'm Dr. Lauren Schumacher. I'm one of the child and adolescent psychiatrists with CAP. I currently am staffing the phone on Mondays, so if you call then, you'll likely talk to me. And then I also see patients in San Francisco and in the East Bay.
Fantastic, thanks. And Mrinal.
Hi, my name is Mrinal. I am the project analyst for the CAP program.
Mrinal is doing a lot of our background tech support, and so her importance to this cannot be overstated either, along with Lauren's partnership in organizing all our CNE activities. If you could go ahead and drop into the chat your name, what organization you work for, what county you work for, and what county you work in, where your practice is. And I've got a little Zoom poll that I'd like to have everybody answer in the interest of measurement-based care. This is the rubber ducky poll. So please rate yourself on the rubber ducky poll, and I'll give everybody a chance to do that. And also, if you haven't had a chance yet, please do drop your name, your organization, and what county you work in into our chat as a way of allowing us all to get to know who you are. Okay, just another second or two, and I'll share the poll results. Okay. So here are the results, everyone. It seems that we've got a couple of people who are feeling like really ready for the day and feeling great. And there are other people at various stages of feeling deflated. I might rate myself as a number 5 right now, myself, because it's been a busy week, as I'm sure it's been for a lot of us. So here are the results here. Thanks, everyone. So, as I said, welcome to our Echo. I think most people have come on in now and have dropped your introductions into the chat. This is our agenda for today. As we get through the introductions, I'll go through a few announcements. Then Dr. Schumacher is going to be giving us a talk on ADHD. And then we're going to move into a case discussion where we learn basically through this interactive case-based learning. And then for those of you who need to drop off at 1, you can drop off at that point. But then for those who can stay, we'll just have a little bit of an extended Q&A discussion for those who can stay for another 10-15 minutes longer. So again, welcome. So since this is our first Echo session, I just want to talk a little bit about what Project Echo is. How many of you guys have actually done a Project Echo before? Can I see a raise of hands? If people are familiar with this, have done this? Okay, so a few people, but not too many. It's actually this really cool international program, and it started in New Mexico, and they trained a bunch of rural PCPs in New Mexico how to provide hepatitis C care at the same level as specialists, clinically indistinguishable from the specialists through this project. And it's basically moving knowledge and equipping PCPs to do what was previously like specialty care. So the idea is moving knowledge and not people into specialty centers. And a huge part of this is community. We learn from each other, all teach, all learn. We're discussing our cases together and we're learning along with each other. We all know something great to share and we all have something to learn. And this works better if, we have this trust as a community. There is no such thing as a dumb question. one quote from a very well-respected pediatrician here in San Francisco, who is part of our first ECHO cohort, is "We all feel like interns again." And so I think this is true for all of us in this space as general pediatricians. And so this is a safe community where we can bring our questions and puzzle through our cases together as a peer community and also with our subject matter specialists. We're doing something new this year. We're introducing something called a CAP Core certification. So the idea is that these core topics like ADHD, anxiety, depression, SSRIs, autism spectrum, and suicidality that we just feel are just core topics in pediatric mental health. These are our 6 topics over the next 6 months. And for those who can finish all 6 topics, we're giving you a little gold star, a special certificate that says you've done the CAP Core curriculum, just to help highlight the investment of time and effort that you're making into this mental health training in pediatrics. So we want to like really highlight that to put into your LinkedIn or to your CV. And we are, as always, offering the AMA Category 1 credit, as well as American Board of Pediatrics MOC Part 2 certification as well, if you finish a post-test or present a case for one of our 6 sessions. And there will be an optional MOC Part 4 activity that has to do with adolescent depression screening and treatment. And that comes by way of like chart review every 2 months that you fill out surveys for. And so look for a survey that will be coming to each of you for you to sign up. If you like, this is completely optional. So these are some of the mechanics here. We're meeting the second Wednesday of every month at noon. We're doing this for 6 months. Mrinal is handling a lot of our technical issues. And so if you've got questions or issues, you can like chat her now in the moment or email her afterwards. Because we are community, please do keep your camera on if you can. And we are all fine with like, this is a brown bag. This is a virtual brown bag, like lunch discussion. And so we are eating, we should be taking care of ourselves. And so please do keep the cameras on. We will be recording the didactic portion only and posting that on our website within a week of this session. And I did ask through our surveys, like who is interested in any given week to do a case discussion, but you can also ping me too if you didn't get a chance to answer at that time. So any questions at this point about some of the nuts and bolts, mechanics of how ECHO works, you can like raise a virtual hand. We might be able to answer some of those there. Yes.
It's very briefly, I apologize for being late. We just went electronic about a year ago. I'm used to using Zoom and this time it wouldn't connect. So I apologize. That's as far as that. Hopefully I'll have it sorted out. I'll try to talk to tech people and find out that I can join on time next time. I apologize. I didn't know if maybe I'm the only one who had that problem, but
I had that problem too.
yeah. So I'm going to go ahead and give it back to you because everyone's time is valuable.
Thank you so much. And yeah, I'm glad that you're on, but yeah, if there are Zoom issues, please email cap.ucsf.edu or mrinal.patel@ucsf.edu for these issues. And hopefully we can help troubleshoot to make sure we can all be here in the future. So with that, I'm going to turn this over to Dr. Lauren Schumacher, who is an assistant clinical professor here at UCSF in the Department of Psychiatry and Behavioral Sciences, and one of the child and adolescent psychiatrists practicing at UCSF many of children's hospitals, and also serving on our CAP consult line. So with that, I'll hand this over to you.
Great, thank you. I'm so excited to have you guys here today and excited to be talking about one of my favorite topics, which is ADHD. So this today it's a very brief kind of whirlwind didactic that will cover some of the main points so that we'll have time for kind of delving in more with the case discussion. If you guys want more, we also are going to have a webinar on ADHD with myself and Dr. Haack, one of our psychologists, tomorrow. So we're, encourage you guys to join for that as well. But today, after this session, you should be able to explain the process of diagnosing ADHD, list first-line treatments, and describe common side effects and how to manage them. And no one involved in the planning of this has any relevant disclosures. Next slide. So I think that keeping in mind the AAP ADHD practice guidelines, I think is a very helpful place to start when thinking about managing ADHD in primary care. And really kind of gets at the heart of what we want to think about. So for when you're seeing kids between 4 and 18 years old, you want to be thinking about evaluating for ADHD when you're hearing things that are concerning in terms of behavioral problems, issues at school, things like that. And when you kind of have those concerns, then you want to go through and make sure DSM-5 criteria is met, ideally getting information from parents, the teachers, and the kid themselves. You want to be looking for co-occurring or other physical or mental health conditions that might be either explaining the symptoms or present with them, and then taking an approach of treating it as a chronic health condition. And we'll talk more about the treatment piece later on. Next slide. So with the diagnosis, you're wanting to be looking for 6 or more symptoms that are present before age 12 and have kind of been consistently present at least 6 months. We've got this list of 18 symptoms. It's really hard to remember all of them and certainly difficult to kind of get through all of those in an interview. So rating scales became a really helpful way to kind of make sure you're asking about them all. You also want to be looking that some of the symptoms are present in multiple settings. So kind of, are they having challenges at home, school, in activities with friends? And then looking for functional impairment. How is this affecting the kids' functioning and how's it getting in the way of things? Next slide. In terms of some of the free rating scales that we often use are the Vanderbilt rating scale and the SNAP, and those have both parent and teacher versions. And kind of the Vanderbilt in terms of research has been used, is validated for 6 to 12-year-olds, but we also do use it for older, for teens as well clinically. And then for self-report for 13 plus, you can use the ADHD self-rate report, the ASSRS. And those are available on our website. And it's helpful to do these both at kind of at the start, both for diagnosis and to give a baseline. And then you can use it to track response to medication and other treatment over time. Next slide. It's also important to think about whether other things are going on as well. It's estimated that about 66% of people with ADHD have a comorbid psychiatric condition. So really comorbidity is the rule rather than the exception. So it's helpful with the Vanderbilt that one has, in the initial Vanderbilt, it has the 18 ADHD rating scales, but it also asks about ODD symptoms and conduct symptoms, as well as kind of depression, anxiety, internalizing symptoms. So that can be a helpful way to get at some of those. And then if there's other things that are concerning to you, you can also do things like, if you're worried about trauma, you can do the Pearl screen, CRAFT screening for substance use, sleep disorders we often see as well. So it's important to keep those in mind. Next slide. So then in terms of treatment, per the AAP clinical practice guidelines, you want to think about psychoeducation, behavioral therapy, which is kind of first line for 4 to 5-year-olds, and then first line along with medication for 6 to 18-year-olds, school accommodations and interventions, and then pharmacotherapy. And the FDA approved medications are first line for 6 to 18-year-olds, and then methylphenidate is second line for 4 to 5-year-olds, with behavioral therapy alone being kind of the first one. And we're going to now dive into those a little bit more. Next slide. So for psychoeducation, it's really about kind of helping the parents and kid understand a little bit about what ADHD is, that it's not something where they're being, intentionally willful or lazy, but that these are things that are harder for the kid. On the CAP website, we have a number of patient resources that you can share with families including information about ADHD as well as kind of behavioral strategies that can be helpful. I also really like the book Taking Charge of ADHD. Has for parents is really helpful kind of introduction and guide to ADHD. And then Attitude Magazine and chad.org are websites that have a lot of helpful information for families and teens. Next slide. In terms of behavioral therapy, there's a number of strategies that can be helpful with managing ADHD. And I think these are all, helpful to keep in mind because for the most part, they're, yes, the most part, they're, parenting strategies that are helpful for all kids, but are especially important for parents and kids with ADHD. And I saw in the chat a question of finding a behavior therapist is really tough. It definitely is. I'll send one. There's one group now called Clarity Pediatrics that's doing kind of telehealth parent management for people with ADHD that take a number of commercial insurance. So I'll can include that in the chat. And then I think also too, there is benefit to, you guys don't have time at all to do kind of full-blown behavior therapy, but you have time to try to put in some nuggets. So I think the one especially, if you have time for nothing else, really that attending quality special time. This is, designated time, can be just 10 minutes of the parent and child together one-on-one doing a child directed activity without judgment. So the parent, it's almost like a mindfulness exercise for the parents, right? They're present in the moment and not judging, maybe like commenting, oh, I see you're using the purple, now you're using the yellow, if maybe they're watching the kid draw, but you're not judging it. So not saying like, oh, you should try to color in the lines, or saying you should draw this here. It's kind of just really trying to increase that connection. So that can be a really helpful one, that even if you have a couple minutes during a meeting with a parent, to really encourage that. Also encouraging use of structures and routines, use of rewards, keeping instructions very simple. You sometimes have, the parents saying, oh, the kid's not listening to anything I do. And then you ask how they're doing it, and they're, 2 rooms over yelling it from the kitchen while the kid's watching TV. And even just kind of a little bit of coaching to like, okay, go to the same room as the kid, turn off the TV, touch their shoulder, make eye contact, then say the instruction and have the kid repeat it back to you can make a big difference. We'll go to the next slide. And then also thinking about school accommodations. So if they're at a public school, these might be in the form of either a 504 plan or an IEP. And ADHD qualifies for other health impairment, and thinking about things like preferred seating, support from the research specialist, extra time on tests, reduced workloads. These all can be very helpful. And on our website, we also have some more information about kind of school accommodations that can be helpful. Next slide. And then the other thing we think about is, of course, treatment with medication. So there's kind of 4 main groups that are FDA approved for treatment of ADHD. We have the methylphenidates and amphetamines. We have the alpha-2 agonists, which are FDA approved both for treatment kind of on their own and in combination with stimulants. And then we have the norepinephrine reuptake inhibitors, including atomoxetine, which has been around a while, and viloxazine, which is a new medication. Next slide. So with stimulants, these are our first line medication for treatment of ADHD. They have a high effect size of about 1 and a response rate of over 70% to kind of a first stimulant, and over 80% with trial of a second stimulant as well. And these really are first line because they're very effective. They've been studied for a long time. They're overall pretty safe. Forward to the next slide. Yeah. They do, have side effects that we often grapple with. Some of the most common ones are decreased appetite, weight loss. Sometimes you can see sleep disturbance, stomachache, headache. Less commonly, we might see behavioral rebound, Generally, with most kids on stimulants, we may see some kind of small increases in blood pressure and heart rate, but more rarely might see kind of more clinically significant changes. And then very rarely you might see hallucinations, primarily with kind of very super therapeutic doses of stimulants. You can also see things like emotional blunting or peripheral vasculopathy. Next slide. Some things that can help with some of the common side effects is with the decreased appetite, really encouraging substantial protein-rich breakfast and dinner when the medication is kind of having less effect, because often we'll see that decreased appetite affecting lunch the most. There is also evidence that in kids with growth concerns that drug holidays or calorie supplementation with things like nutrition shake can be helpful. It's also helpful to get a sense at baseline of what they're eating at lunch is, because you can also often kids with ADHD, you know, if you picture back to when you were in elementary school and what your lunchroom cafeteria was like, it's a little bit distracting. So often, even when they're not on the medication, they may be the kid that is not eating their lunch because they're talking to their friends, they're going from table to table, and they're getting very distracted. So it can be helpful to make us have a sense of that it's definitely the stimulant that's causing that effect. If they're having stomach aches, make sure they're eating it before taking the medication. And sleep disturbance, you want to find out what time of day they're dosing it, have them shift it earlier. Consider shifting to a shorter acting formulation. And then also could consider adding melatonin or an alpha-2 agonist, or switching to an alpha-2 agonist or atomoxetine. And this is another one where it's important to get a sense of their sleep at baseline, because very often kids with ADHD at baseline have sleep challenges, so it might not even be the medication. And then if they're having issues with rebound, where kind of as the medication's wearing off, the symptoms of ADHD are coming back even worse than before, then to think about switching to a longer acting agent or adding an afternoon booster dose to kind of smooth down the kind of decrease of medication. Next slide. I think a common issue that comes up is how to choose a stimulant. There's many choices out there, and that's partially because there are such effective medications that all the different pharma companies want to have their own. But things that are helpful to keep in mind is first the mode of administration. So can the kid swallow pills? If so, then there's a lot of different choices. If they can't, then you want to think about capsules that you can open and sprinkle, chewable options, liquid. There's also patch. It's helpful to think about the duration of action. We have short acting ones that are more lasting like 4 to 6 hours. There's kind of medium acting ones that last about 8 hours, and then long acting ones that last more like 12 hours. So thinking through, like, is this a young kid that has a shorter school day and no homework? Is this a high schooler that has a long school day and activity and homework and really needs a longer acting duration? And at this point, there's really not evidence that pharmacogenetic testing is helpful clinically. Next slide. This is helpful. Online, there's an ADHD medication guide, which can be helpful to reference. It has pictures of all the different medications. And next slide. Next slide. And then for the sake of time, I'm going to skip over this, but this kind of just goes into some of the things to be checking in on both when you're first starting, and then things like vitals to be checking on as you're kind of monitoring their use of the medication. Next slide. And then we have the alpha agonists, guanfacine and clonidine. They have a more medium effect size of about 0.6. Next slide. And by far, the most common side effect is tiredness. So that's kind of the main one we look out for, as well as possibility of hypotension or dizziness. Next slide. And a great thing about the alpha agonist is that we really don't see changes in body weight. So this is a good option for kids that have really struggled, either kind of at baseline, have growth concerns, or have issues with the side effect of appetite suppression on stimulants. And in terms of managing the side effects of guanfacine and clonidine, it can be helpful if they're having tiredness with it to dose it at bedtime. Clinically, guanfacine tends to be a little bit less sedating than clonidine. And then if there's issues with like dizziness, making sure they're staying well hydrated, sitting up slowly after lying down, checking on blood pressure. Often this is something you see kind of when they first start the medication or dose change that gets better. But if it persists, then thinking about switching to something else. Okay, next slide. And then with atomoxetine, this one also has a medium effect size of about 0.6. And you can see the side effects listed here, but kind of the one that comes up the most is kind of gastrointestinal symptoms, nausea. It can be helpful to start by dosing the medication twice a day, so dividing it up. And then after a couple of weeks, if they're tolerating it okay, then consolidating into once a day dosing. And that can help with some of the side effects as they first start. And next slide. And then viloxazine is similar to atomoxetine. It also has effect size of about 0.6. It's the newest ADHD medication approved in 2021. And one of the nice things about this is it can be opened and sprinkled. So if you have people you're thinking about atomoxetine for, but that can't swallow pills, the viloxazine is a good option. And next slide. So kind of just to summarize, kind of for all your ADHD kids, you want to be thinking about kind of encouraging healthy activity, nutrition, sleep, and then click again, thinking about school accommodations and behavior therapy. And then either first line for over 6 or second line for under 6, then going to stimulant medication. You want to optimize the dose of that. And then if there's issues with side effects or no benefit, then switch to the other class of stimulants. So switching between your methylphenidate and amphetamine, optimize that dose. If issues with side effects, then you think about going to either an NRI or an alpha agonist. And if there's issues with that, then thinking about switching to the other one of those. You can click again and click again. And then at that point, really, if they're continuing to have issues, you definitely want to be thinking about differential diagnosis. Are there other things going on that are kind of explaining why they're not responding? And then can also think about other non-FDA approved medications that would be appropriate. And then in terms of sleep, you can think about sleep hygiene, of course, and then potentially melatonin and alpha agonists. And all right.
Thank you.
It's an option. There's not a lot of great data for it. I think there's a couple of case reports of using ciprofloxacin as an appetite stimulant in ADHD. But it is something you can try. I think kind of trying a couple different medication options would be kind of where I would go first. So both, if they're on an amphetamine, potentially switching to a methylphenidate, because we do know that while both can decrease appetite, for a given individual, they may have less effects. And then, of course, kind of the behavioral strategies of considering medication holidays, trying to boost nutrition, especially when times where they're less hungry. But if kind of those are happening and, they're still having issues with their appetite, then it's certainly something to consider.
Thank you so much. So at this point, we're going to go switch over out of the kind of the didactic portion into the case discussion. Other questions that have come up? Yes, Karen?
Oh, I was just saying thank you. I have to run, but very good presentation. And I didn't know about some of the screenings that you had listed there, so that was very helpful. I have tried to use the Vanderbilt, but it's very difficult for them to get the 3 different sets, from a teacher. Teachers are refusing to do it. They can't find a second person, that sort of thing. And so it's challenging just to do that.
Yes.
We do the ASQs, that's okay, but doesn't always pick up anything. But I will learn more next time. Thank you.
Sure. All these rating scales are on the CAP website as well. And so if you're wanting to check out the SMFQ or like the SCARED for depression and anxiety, Those are on the CAP website. And yeah, I agree. Getting rating scales from teachers is like one of the biggest pains in the butt part of ADHD diagnosis and treatment.
But she was mentioning 3. I usually just do the teacher and the parent.
Yeah,
Is she
usually I
supposed to
do a
get a
teacher
third?
and a parent.
Okay.
Not necessarily, but a teacher and a parent is what you want. Dr. Parek, I don't know if we can hear you. You're muted.
I have a question. In this kind of the case, we don't get the therapist right away. So it's okay to start with the medicine while waiting for some behavioral therapist to work on it. Is that right?
So for kids 6 and over with ADHD, medication is considered a first line treatment. So absolutely fair to be starting ADHD medications here. And the therapy, I think, was because people were wondering, could there be some depression? Could there be some anxiety? And really helping the child to work through the increasing anxiety and depression that may be there, which happens a lot with kids with pretty bad ADHD, because they get in trouble so much, they just start getting really sad about themselves, really anxious about everything. And because the comorbidity with learning disabilities is so high, if there's some element of that too, they their mood can go south real fast.
So even with having some kind of the comorbidities, still is okay to it's good to start with the ADHD medicine.
Yes. If we think ADHD is the primary problem, we want to start with stimulants.
Okay. And for you always start with the Ritalin first?
I usually start in the Ritalin class because the side effects are somewhat less. Side effects tend to be somewhat less in the Ritalin class.
How do you like to dose that up? What dose do you start? Just take a random 7-year-old.
Random 7-year-old. It depends on what's on their formulary and how long they want it to last. Okay. So your typical 7-year-old who's in the first grade, it's often hard to get that midday dosing at the school lunch hour, right? So I actually usually start with a longer acting formulation. They often have trouble swallowing a tablet. And so I like a capsule form that you can open up and add to a little bit of like applesauce. So Ritalin long acting is intermediate acting, actually. And so that will give you 6 to 8 hours. It'll take you through the school day. You don't need that second midday dosing. It's kind of half the beads are immediate release, half the beads are delayed release. And so it approximates that twice a day dosing and usually tends to run out around 2-3 p.m. Like it's coming out of the system around 2-3 p.m. as school is getting out. And so for the younger kids, that is sometimes what I do because then it's more or less out of the system by the time dinner comes around. Like we want them to eat a good dinner because they've often skipped lunch, like more often.
Homework at 3.
Homework at 3. Well, at 7, usually homework is not a big deal. And hopefully there's
It's
enough.
taking the 7-year-old, the grandma say it's taking an hour and a half to do his homework.
Then you might want to go with something a little bit longer. So Ritalin long acting is actually an intermediate acting medication. Concerta is longer acting, but that one needs to be swallowed whole. You can't crush it. You can't open it up. That's a tablet and a decent sized tablet. But Concerta is longer acting. Adderall XR is a capsule and it'll last through the day. Right. So that's another possibility there. Focalin XR, like I will usually get kind of something a little bit longer than Ritalin long acting out of that, but it's kind of more like similar 6 to 8 hours, but it's also nice. It's in the Ritalin class at 6 to 8 hours. It's a capsule. But for a kid who needs something longer, it depends on how long you need it to last for, right? Okay. And what's on their formulary and what they can get down their throat.
Because I was just starting with the Ritalins, because this is kind of new. I haven't done a lot of it. So it's just starting with the little Ritalins. And then school was doing fine, but then they were having trouble after. And so they just wanted higher. And I was like, well, school's fine. Or, you still have the same pills, but they're saying, well, they have structure in school. They've got resources in school. They have behaviors in school. They have all that. But now they're at home. We need something extra.
Yeah. There are a couple of approaches to this. One is if that Ritalin was acting well, through the school day, you could do like a half tablet in there right as they come home from school, right? or, you know, as they're picking out, right, just to get them through the afternoon and homework. That's one option is
It was
add
weird because they were doing more after school than at school. Because I gave them the 5s to work with.
Yeah. I would just worry a little bit about if you gave that full 5 milligram dose and it was perfect for school, right? And then you're giving
Well,
this
no,
at
they
2 or
went up to
3.
20 and 20 by the
20 and
end.
20. Oh, got it. I see what you're saying. 20 and 20. I would not give another 20 at 3
No, I
p.m.
didn't give another 20,
Yeah.
but they ran out of 20s at the pharmacy. So
Yeah.
they recommended like Concerta 18. And I thought, oh, great. That's a good way to get them less because it's
Yeah.
summer. They're not in school. Yeah.
Concerta 18 doesn't like correlate with Ritalin 20 and 20. So there's
Right. It's not as
there are
high.
ADHD
Yeah.
calculators. Let me see if I can find the site for you.
No, it
that'll
would be
kind of do
more
the
like
calculation.
54 or something, but
Exactly. Yeah,
they've been on the 18 and they've not complained. So I'm happy to have them do less.
sure.
But
Yeah, if it's working,
I
it's
don't know.
working.
I'll see them next week and we'll find out.
Yeah. Summer may be different from the school year too.
Yeah.
Summer may be different from the school year, but when I'm switching between medication formulations, I like the ADHD medical calculator to help me to estimate what the dose on that new medication should be. That
So
would be
where's
equivalent.
that?
ADHD MedCalc. It's in the chat. I just put it in the chat here.
Oh,
Yeah. It's I use that when I'm switching formulations.
Okay.
So that's just a quick way.
okay, great.
Because in general, Adderall, like the dosing, like 5 milligrams of Adderall is equivalent to 10 milligrams of Ritalin, right?
Mhm.
And Vyvanse, you just can't calculate that easily. Concerta just doesn't calculate easily, right? And then, yeah, and Focalin is like, again, 5 milligrams of Focalin is 10 milligrams of Ritalin. So, but it's hard to keep that all straight. And so sometimes it's easier just to use an ADHD medical calculator.
Mhm. Great.
Yeah, thank you so
Yeah.
much for being willing to
All right.
come
Yes.
up with the case like today. Like I went with the first person who answered, and I appreciate your
Yeah.
willingness to step forward. You know, like especially the first time, it takes a certain amount of just like courage. So thank you.
It was great. Mhm.
That's good. Thank you.
Thank you.
All right, we'll see you next month.
Okay.
And take
Bye.
care. Okay, goodbye.